Good morning. My name is Marvin Atkins. I'm a cardiothoracic and vascular surgeon here at the Houston Methodist DeBakey Heart and Vascular Center, and I welcome all of you to After the Grand Rounds lecture here with our esteemed guest, Dr. Michael Mack. Dr. Mack is a luminary in the world of minimally invasive cardiothoracic therapies, and specifically in the world of transcatheter aortic valves. Dr. Mack, thank you so much for joining us
Marvin,
here.
Glad to be here.
Yeah. So before we get started, I'd like to remind everybody, if you'd like to submit questions for us, please go ahead and text DeBakey to 37607, and we'll be able to get those questions and be able to share that with everyone here in the audience. Dr. Mack, thank you again for joining us. And I guess the first question we'd like to kind of discuss is kind of delve a little bit deeper into the world of transcatheter aortic valves. This past year has been kind of a seminal year in terms of the rollout of TAVR into the community hospitals, into other institutions besides those that participated in the major trials. With the national coverage decision that was released a few months ago, it's really kind of opened the doors, despite what some of the major societies had recommended in terms of numbers of requirements, heart team approach, those types of things. And it's really kind of changed the world of TAVR. I'd like to get your thoughts and just kind of see where you think things are, where they're headed, and where we should go from there.
Well, what CMS tries to do is to balance quality of care with access to care. It is their responsibility to be sure that Medicare beneficiaries get the best possible quality care, but also as they have adequate access to care. And the problem is how you balance those two. And can you have low volume programs that have same quality as high volume programs? Or can you sacrifice some quality to have better access to care? There clearly is a volume outcome relationship with TAVR. It probably is not as strong as it is with some more complex open heart procedures, but it's like anything else in life. The more you do, the better you are at it. Now, there's 1,150 cardiac surgery programs in the United States. There's about 670 TAVR programs in the United States. There have been about 35 or 40 that have opened just since the new NCD was approved. With the current parameters that are in place, it's estimated there will be about 850 programs total over the next 2 years. The problem is, in the U.S. healthcare system, geography is not the main barrier to access. It's payers, it's providers. It's, as you know here in Houston, that there's so many different healthcare systems and payers that nobody's going to cross from one to another. So it's the barriers in the healthcare system per se, more than geography, that provides the problems with access to care.
Have most of those new programs that have they opened up in urban areas or rural areas? And most of them, I would assume, would be just in the larger cities, just smaller satellite programs.
Yeah, and that's exactly right. It's the same thing's happening in Houston as is happening in Dallas from that standpoint. The overwhelming majority of the centers are in the concentrations of population. Yes, there are some that are opening in rural areas that are helping this geographic access to it. The current requirements by the NCD is that you're going to have to be able to do 20 a year. And whether that's enough to be good at it or not is going to be remains to be seen. My guess is that there will be some low volume programs that open and end up closing because it's not sustainable. But it is what it is at this stage, and we'll see.
What type of enforcement of those kind of numbers do you foresee, or how does CMS kind of control some of that?
There's
auditing.
There's no formal policing aspect per se, or enforcement enforcement arm except for the fact that the threat of a Medicare audit or a Department of Justice audit of that you meet the criteria that is set forth in the NCD. And so, you know, you're always afraid of Medicare fraud because you're not in compliance. Sure. So that's the policeman, if you would, to enforce the NCD.
Gotcha. I guess the next question I'd like to talk about is we have two or almost three devices now that are approved in the United States, two of them with large multi-year randomized multiple clinical trials that have shown its equivalency or if not improvement compared to surgical AVR. Now we're going to start having all these other Me Too type of devices that roll out. How do you foresee them being sustainable? How do you see them changing TAVR in the United States?
So, you know, the more the better, number one. And competition's always good. It'll always drive everybody to get better. The more products you have in the market, it will have an effect of eroding prices. So the costs of the devices, you know, will gradually start coming down over time, the more devices that there are in the market. And then we'll figure out which devices are best for which particular conditions. So for example, Dr. Reardon and myself just discussed this in Europe a couple months ago, that probably 80% of patients will do just fine with whatever valve is available. But there's particular niches like bicuspid valves or heavily calcified valves or small aortic roots that'll do better with one niche device or the other. So I think all this will sort itself out in the clinical marketplace of knowing that for this particular condition, this particular valve, be it a self-expanding valve or a balloon expandable valve or a mechanically expanded valve, or a valve for aortic insufficiency, for example, you know, will win out.
I guess one of the things that we've seen in vascular surgery in terms of the role of EVAR and TVAR for abdominal aortic aneurysms, thoracic aortic aneurysms, as further devices got approved, other companies came in, it takes so much money to get these devices to market that industry has to, you know, be able to recoup some of those costs. What we've actually seen is that the costs never really kind of came down and they continue to slowly climb. I guess as you know, more TAVR companies come out and their devices come out because it's so expensive to get them, do you really think that devices costs will come down, which is really one of the biggest barriers these days?
So, you know, there's a couple answers to that. You know, the first is that what had happened is innovation and device development had been driven out of the United States to overseas. Right. And so the fact that innovation was leaving the United States, our regulatory agencies, the FDA, heard this loud and clear, and they made some significant changes to bring innovation back to the United States. So for instance, we were able to do first-in-human and early feasibility trials in the United States now, right. Thanks. It's not that the FDA laxened the regulations, but they made it so that, you know, that device innovation could happen in the United States for the first time. Now, the FDA is fully cognizant of how burdensome and expensive clinical trials are, and they're very committed to be able to generate evidence in other than large randomized trials that cost $50 to $100 million per trial. You know, that's the cost of a large pivotal trial right now, and that's not sustainable in the future. So the FDA is very innovative about trying to develop ways of generating evidence of safety and efficacy without the expense, burden, and time of large randomized trials.
Okay, great. I guess the next kind of topic to discuss is training paradigms. So the role of cardiac surgery has dramatically shifted in training, at least over the last several years, to really pushing heavily on endovascular, both in the role of transcatheter aortic valves and mitral and other types of interventions. Where do you see the training for cardiac surgeons in the United States in the next 5 to 10 years in terms of how do you learn all of the open surgery, things that are still important, things that are still going to be necessary, and add on all this other endovascular skill sets all within a 2 to 3 year type of period? Do you see kind of subspecialization, or where do you see training going these days?
Well, I see a lot of the changes. We use the examples of what happened in vascular surgery, per se, to be able to develop the surgeons that have the appropriate skill sets to be able to perform endovascular and transcatheter procedures. I think that TAVR is only the tip of the iceberg. As you alluded to, mitral and tricuspid will come soon after that in trials at the current time. So the American Board of Thoracic Surgery has just changed the training paradigm for cardiac surgeons. You can now get a separate certificate in cardiac surgery without thoracic surgery, which has always been combined. There will be less time spent in general surgery and more time spent in the cath lab learning wire skills, learning imaging, both echo, CT, et cetera. And then there'll be there's a proposal for a common structural heart fellowship open to both cardiologists and surgeons. That's an ACGME certified fellowship. Right now there are fellowships that are open that are non-ACGME certified, but the idea is we're now at the time of structural heart disease that training needs to be formalized. So the training will change both for during training, getting more experienced in imaging and catheter-based skills, and then the opportunity for super subspecialization afterwards in structural heart disease.
That's great. Great. I think we've got a couple questions from the audience. First one, how many valve and valve TAVRs can be done? What happens if they need open heart surgery at 70 to 80? Especially as these low-risk trials have now come out and suggested equivalency compared to open surgical repair. Patients are getting younger and younger. What about valve and valve and valve and valve?
Well, you get to the Chinese doll or Russian doll, analogy of how many dolls can you put inside the doll. Right. I think realistically, after you have a valve and valve, it's going to be much more difficult to do a third or a fourth. Okay. I think that we are going to be facing, you're going to be facing, not me, a large number of individuals that are going to need complex open heart surgery 10 and 15 years from now. After their valve and valve, they're going to need an open surgical replacement. Right. And it's going to be a complex aortic root. You're going to have to do an endovascular explant of it. Mobilizing scarred coronary arteries to reimplant are going to be difficult. So there's, first of all, cardiac surgery is not going away. Right. It is going to become more complex. And the way you have to think of it is, as a younger patient with aortic stenosis, you're going to need an operation at some point in your career. There's no valve operation that's going to cure you for the rest of your life. And it's going to be figuring out when the correct timing of that surgery is. Is it first? Is it third? Or is it fourth on down the line? And so what age you're going to need surgery, I think that's going to be the trick of figuring it out.
Right. One of the things I struggle with these days is the patients I see in the office, under 70 years of age, a bicuspid aortic valve, and then which pathway do you go down in terms of setting them up down the road for possibly a next operation? Do you put in a mechanical valve? Do you do an open surgical valve first when they're a younger age, and plans of down the road they may need a TAVR? Mm-hmm. Do you go up front with a TAVR with plans for an explant down the road? How do you kind of foresee that treatment? What's the algorithm kind of in your head? How do you manage those patients?
Well, I think we have moved from a paradigm that the first assessment of a patient was risk of surgery. Mm-hmm. We're now beyond that, and age is going to be the initial criteria. So you look at a patient's age to begin with, and the first decision is tissue or mechanical. And I would say right now, if you're under 55, mechanical would be the preferred choice, but it has to be a shared decision making with the patient about the need for lifelong anticoagulation. Right. If you're over 55 to 60, then it's probably tissue. Then once the decision gets made for tissue, is it TAVR or is it SAVR? I think if the decision's tissue, if you're under 65, strong consideration should be surgery. If you're over 80, the default answer is TAVR. Between 65 and 80, it's a shared decision making with the patient. So that's where I see that we're at right now, but it is going to be much more complex, as you've alluded to, as to the endless permutations of what could happen with a lifetime of disease.
In terms of TAVR and the surgical valves, now we're finally getting to more robust, longer-term follow-up in these patients. Are you seeing a lot of structural valve degeneration?
Yes. You know, as you know in surgery, you never want to do or redo anything.
Right.
And I thought valve-in-valve was going to be a great answer for structural valve deterioration. However, we are seeing patients back sooner than we expected, and I'm not sure it is the final answer. So there's actually a proposal at the NIH right now of doing a randomized trial of patients with surgical structural valve deterioration between a valve-in-valve versus a redo surgical aortic valve replacement. So whereas a year or two ago I thought we had found the solution, I'm not so sure that that's the case, and I think that the valve-in-valve may not be as sustainable long-term as we thought. And it's going to be true in TAVR. Things are never as good as they look on the front end, and there's going to be other bumps in the road.
Great. Well, I think we're getting close to the closing time here. We'd like to thank Dr. Mack so much for joining us here at the Houston Methodist DeBakey Heart and Vascular Center. Thank you very much, Dr. Mack.
Thank you, Marvin, for having me.